Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Well, Tracy, this may not be the most pleasant topic we've ever discussed.
Is that a warning?
That's a warning.
Okay.
Problems with the rectum.
Okay.
Now, they're all too common, and almost everyone will experience some rectal itching, pain, or bleeding at one time or another during their lives. A lot of the time, these problems they're minor. They're no big deal, and they get better on their own, maybe with a little over-the-counter medication.
But in some cases, a trip to the doctor for testing and diagnosis may be in order. Here to discuss common colorectal problems is Mayo Clinic colorectal surgeon, Dr. John Pemberton. Dr. John Pemberton, welcome back to the program,
Thank
Dr.
you,
Pemberton.
Thank you very much. It's very good to be here.
Dr. Pemberton, it's so nice to see you. And this is probably trip number 10 for you over the years, huh?
We stopped counting.
Yeah, and you've always been so good about coming
you're
here.
Very nice.
And, you know, we so appreciate that there are people like you who are willing to take care of problems down there.
Yeah.
How is it that you got interested in being a colorectal surgeon?
I don't know the answer to that question.
You're still
Tom.
asking yourself that, huh?
I am. 40 years later, I'm still asking. Yeah.
But when people do have rectal issues, pain, whatever it is, they are very happy when they finally decide it's time to go ask for help.
Exactly.
For
Exactly right.
what help you can offer them. So what's the main reason that people come and see you?
Well, the main problem that people have that come in off the street, you know, in other words, not referred in by their doctor, are itching and discomfort, difficulty with evacuation, sometimes some blood notice on the toilet paper. Those are the biggest things that they have. A few have pain. And we can talk about the causes of that.
Well, is it mainly hemorrhoids?
No, I think one of the misconceptions, common misconceptions that patients have, that people have in general, is that hemorrhoids cause pain, and basically they don't.
Really?
No, if pain is a primary complaint of a patient, almost always they have some form of a fissure. An anal fissure, a fissure.
No, what does that mean exactly?
It's literally a crack in the skin or the lining of the very outside of the anus, and it happens very commonly. It happens mainly because patients have hard stools, and it literally can crack the skin.
So the caliber of the stool is so large
caliber
that it cracks the skin.
Firmness.
Okay.
And then what that does is it makes a small little crack in that skin, as I said. And then the underlying internal sphincter muscle, which is right there, and it's almost always posterior towards the coccyx.
Okay, in the back.
That exposes the muscle, and the muscle goes into spasm. And it's a cycle. The fissure causes a spasm. The spasm keeps it from healing. And so our approach is a stepwise approach to the management of those problems, but it's mainly geared toward or aimed at stopping that spasm.
So how do you get the thing to heal and people continue to have bowel movements?
It's a 3 or 4 step process with us. First is changing habit and using a lot of stool bulking agents like Metamucil or Consol or Benefiber, things like that. That changes the caliber of the stool and the consistency of the stool so that it's more easily passed, less likely to cause disruption of the skin. Then if that management technique isn't helpful, then the next step is the use of topical agents meant to relax the sphincter muscle.
Really?
Again, breaking the cycle is the key.
Tell us about this condition, as long as we're talking about pain. Did you finish there? Did I interrupt?
No.
Okay. We got through step 4.
I know, I haven't. I only got through step 2.
Okay, that's sorry. I didn't mean to interrupt. Go ahead. We need 3 and 4.
Yeah, okay, 3 and 4 then. If the topical agents don't work, then we have been for the last 5 years, 6 years maybe, been injecting Botox, believe it or not, into the internal anal sphincter. Again, with the idea of relaxing it, breaking the cycle, and stopping the discomfort and the bleeding that accompanies that at times. The last step is an operative intervention. It's called a lateral internal sphincterotomy, meaning, again, breaking the cycle, taking the spasm out of the internal sphincter muscle by an operation. But that is associated with some problems potentially. Up to 30% of patients will experience some form of incontinence to gas, mainly. Over time, over a 3 to 4 year follow-up, that drops down to less than 1%. So it's a temporary problem, but nonetheless, enough of a problem so that we try the first 3 steps first.
All right, before we talk about rectal itching and hemorrhoids, which are more common, tell us about this condition called proctalgia fugax.
Oh, that's a tough one. That's a tough one. It's a symptom complex that almost always occurs in, perhaps interestingly, more type A personality people who are really hyper all the time. And they have problems with deep-seated rectal discomfort. And it's mainly, if you examine those patients, you can often find spasm and tightness in the levator ani musculature, which are the muscles that form the bottom of the pelvis through which the anus travels. And if you can relax those muscles, the proctalgia almost always disappears.
Severe rectal pain caused by muscle spasm, and usually goes away spontaneously, and there isn't really anything you can do about it.
Well, you can, with proctalgia fugax, address sphincter relaxation and what's called shortwave diathermy, which is useful in the management of a tense pelvic floor that is relaxed by shortwave diathermy. Very interesting.
How about hemorrhoids?
What about them?
All right. Rectal bleeding. Most rectal bleeding is caused by hemorrhoids.
Yeah.
Myth or matter of fact? That's it.
Yeah.
Okay. When should you go in and see your physician?
I think if it's more than just toilet paper blood, if you have a little smear of blood on the toilet paper, I would counsel a patient on the telephone, perhaps, of using more stool bulking agent, like a Metamucil and so forth. And trying to change the habit and not strain at stool. But if that doesn't work, or if there's dripping of blood into the toilet, that's a different story. And one drop of blood in the toilet looks terrible. It really makes patients freak out. So I guess if there is more than toilet paper blood, they should probably contact their physician.
If there is I would imagine people put off coming to see you when they have any sort of issue whatsoever. Is there ever harm that results from that? Or is it just you saying, man, we could have taken care of this for you a long time ago?
No, I think harm is not part of the equation.
They just could have gotten relief a long time before.
I've heard you say before that the main cause of hemorrhoids, almost the primary cause, almost the only cause, is straining at stool.
That's correct. You're exactly right.
That is true.
And so that's why the management is of hemorrhoidal disease, if a patient really does have problems with hemorrhoids, is directed towards changing that dynamic, changing the habit.
But you can fix hemorrhoids, right?
Yeah, you can fix them. You can fix them mainly with 2 forms of management. One is banding, and one is hemorrhoidectomy.
Like you put a Band-Aid around it. And
you put a rubber band, actually, on the hemorrhoidal group, high up in the anal canal, away from the sensation part of the anal sensatory area of the anal canal. And that can keep them back up, that pulls them back up inside, keeps them from prolapsing down into the anal canal, and eliminates bleeding in about 80% of patients.
Bigger problem for men or women?
Either one.
All right, one thing we haven't covered, 15 seconds left. What do you do about rectal itching?
Try not to itch. And the biggest problem, the biggest thing we see is some of the over-the-counter, or the biggest help can be some over-the-counter medications.
All right. Thanks so much, Dr. John Pemberton, colorectal surgeon, talking to us about common colorectal problems. Appreciate having you on the program.
Thanks,
always.
Guys, very much. Appreciate it.